I'm a geneticist. I do cancer genetic studies of various types of cancer, breast cancer and pancreatic cancer mainly. I do inherited cancer research, so I'm looking at the BRCA1 and BRCA2 genes and then panels of other predisposition genes that influence that, and we're trying to figure out the risks associated with mutations in those genes. The presentation was on a pancreatic cancer study. We took 3,000 pancreatic cancer patients collected at Mayo Clinic over a 15-year period, and we screened them for mutations in predisposition genes. This really hasn't been well understood to this point. We know that BRCA2 and ATM might have a role in pancreatic cancer, but we didn't really understand the other genes. So with the QIAGEN panel with 37 genes on it, we were able to really establish a role for 8 different genes in pancreatic cancer, put approximations of risk on those, so now the clinicians can actually estimate how much risk a person would be at if they're found to have a mutation like this, and then look at some of the family histories, see if they've got breast cancer, ovarian cancer and other cancers that go with the pancreatic cancer. We had tried a number of different technologies to evaluate a large series of genes, 37 predisposition genes at one time. Could not find another panel that could work efficiently for us and had a high throughput approach to it. So with that, we partnered with QIAGEN. We were able to put 37 genes on the panel, and we found a tremendous conversion rate. What I mean by that is the percentage of target genes that actually gave us back good results. So we're over 99.6% efficiency on this panel, and we've not seen anything remotely like that with any other technology. So this has allowed us to then go forward and be very, very confident of the results that have been coming out of our mutation testing. So the study was on pancreatic cancer, and we think where we'll go with this is try to push some clinical trials in the area of BRCA1, BRCA2 and ATM mutation carriers. We currently don't know what types of drugs they can benefit from, but they clearly are different from other pancreatic cancer cases, so we'll be pushing for clinical trials in that area based on these data. We also are doing big studies in breast cancer. We are trying to figure out what the population-based levels of risk are when you have a mutation in one of these predisposition genes. And to do that, we've partnered up with about 12 centers around the United States. We have 40,000 breast cancer cases and 30,000 controls that we're testing on the QIAseq panel. And the outcome of all of that should be very accurate risk estimates for each of those genes, and then the patients will know how to move forward.
QIAGEN.
Sample to insight.